Thank you so much, sir, for presenting a very interesting case. Let's move on with Dr. Ajay Aurora's case. Ajay, sir, please share your screen.
I just, is it visible?
Not yet. Yes, coming up. Yeah.
Okay. So thanks, Jay. Thanks, Evers, for this opportunity. So I'll be presenting a patient with giant retinal tear with advanced PVR and a search for the black box. Now, basically, this patient had injury. This is the past in April 2020, underwent cataract surgery. He had an injury while he was an onlooker. Somebody was, hitting a bearing of a bike, and he had an injury. And patient underwent cataract surgery and IOL. Patient improved extremely well, 6/9 vision, which subsequently deteriorated to 6/12. He had PCO, underwent yak capsulotomy, which was in June 21. His vision at that time was 6/24. He was asked to undergo a B scan. The patient was seen by somewhere. The patient had come from outside actually, and was advised to undergo a vitrectomy in belt buckle. He had been seen by a retina surgeon here, and he presented to us on 27th of December. His right eye was good, visual acuity was 6/6, while the left eye has hand movements. The pressure was low. He had a corneal scar, there were posterior synechiae. There was an area of iris Bombay with an aqueous retrolental flare with a yellowish fundal glow, could not see the details, and we planned out further via surgery. So this is what the ultrasound showed. You can see how the retina looked like. There was a corneal scar, as I mentioned, and we went ahead and did a vitrectomy, perfluorocarbon membrane surgery, and a PFCL silicone exchange. I'll just show you the surgery. So this is the patient. Initially, when I started off with there was a rusty colored fluid in the AC, so I put in visco, did a vitrectomy. This is vitrectomy being done in the subretinal space. Tried to find out a cleavage plane where I could open up the funnel. I thought I had found a plane, and I injected perfluorocarbon liquid here. But unfortunately, perfluorocarbon liquid all went into the subretinal space. You can see here, I was clearing up the PFCL from the subretinal space, and then we tried to figure out where the flap was because they were all adherent. Finally managed to find the cleavage plane and put in perfluorocarbon liquid. You will see that the retina started settling down well. So whatever vitreous was there, we removed it, settled the retina, and did laser for this patient adequately. All throughout, what I noticed was that in the subretinal space or in the vitreous cavity, the fluid was looking a little rusty. And that was, annoying me throughout as to why this color is different from what we normally find when we do our detachments. So he was a young boy. We went ahead and did a silicon PFCL exchange, and the retina settled reasonably well. Completed the laser. You can see her retina settled pretty well. And last remnant of PFCL I'm trying to remove, and that's the end of the surgery. So then this is his post-op. His visual acuity now, about 2 weeks back, is 660. There's a PCIOL. This is a silicon-filled eye. And we could see, so you can see here a small little corneal wound. There is an iris hump here. Then because I was not happy, I got a CT scan done. And this is the picture on the CT scan. You can see here there is a foreign body. You can see there is a radiopaque shadow here. It's a globular shadow, and this is, you can see the streak artifacts, which proves that this is a foreign body. We talked to the radiologist, and he says, so this foreign body is possibly lying between the IOL and the iris. And there's a globular shadow here, which I would, so now the question is, how and when do we remove the intraocular foreign body, and what that globular shadow is? And will removing this intraocular foreign body arrest or reverse ocular sidrosis? And how to handle the radiopaque shadow? So I'll take the questions here from, take the opinion of the panel here.
Great case. Sir, what is the IOP at this point of time?
The IOP was 14 when I last saw the patient.
I think that, yeah, Dr. Hemant.
Yeah, I think that other radio opaque shadow might be PFCL bubble. Is that
Correct. Because I was very
generally
surprised.
does
So we
show
looked
that.
up, So we looked up the literature, and it seems that this PFCL presents as a radiopaque shadow. It does not show streak artifacts, and yes, it looks like PFCL. So my question now is that I'm going to remove the intraocular foreign body by an anterior route, because it is possibly lying between the iris and the IOL, by doing an anterior magnetic handshake technique, which means that we will put in a magnet and also have the forceps, because this foreign body has been lying for more than a year and a half in the eye. He has undergone surgeries, he has gone through multiple examinations, but the foreign body has been missed. So this was just a gut feeling because of the rusty fluid that I thought there is a foreign body. What my question would be, when I eventually remove the silicone oil, should I attempt to remove the PFCL, which is a thin sliver of PFCL lying in the subretinal space, or just leave it?
That I think will come to. I just want to add on one point. In your B scan, you can actually make out that it's a GRT. So if you look at the B scan, if you see the flap of retina separate, that means there is a GRT. Otherwise, whenever you have a PVR, the anterior edges are attached and you always have a funnel shape which comes in. Here you can see the flap that is there. So you know that
it was actually closed virtually, anteroposterior. So I thought I had found a plane. I knew I was going to, so it was closed like this, it was closed like that. And I was trying to open it up, but I could not. And then I found that, okay, went back and it worked out.
In the removal of PFCL, you can use a 41 gauge needle and try to do it. It does come out sometime. So some of the other ways of
it will be present around the disc area.
Okay.
Sir, I just wanted to ask you whether you did the silicone oil PFCL exchange by injecting silicone oil through the infusion cannula.
Yes, as we normally do, because we normally use a chandelier. So we do some simultaneous removal of the PFCL with the silicone oil injection at the same time.
What I have found is that, if you are doing it through the infusion cannula, like we used
not the infusion cannula, and the superior temporal port, because if you inject it through the infusion cannula, sometimes the infusion cannula blows off.
Yes, that's what
so So
once you moved into the small gauge, it is very difficult.
Correct. So it was injected through the supratemporal port.
Just to say that, you can do this with a small port. What you can do is just take out the cannula and use the trocar cannula system, the tip, and inject it directly through that port. Actually, you can do it. You can use the injector to put it directly without the infusion cannula. It does not have any.
So Hemant, this was done by removing. So what I think Gopal was asking is whether he do it through the infusion cannula, because both my hands were occupied. One hand was, removing. We had androlite on. The other hand was removing the PFCL. So you can always ask an assistant to put it through that port, and you can inject it. So that's not a
So, any other comments? So I nowadays use Bausch & Lomb Duo Yaw, which helps a lot in exchanging the direct exchange with silicone oil and PFO. That seems to be very useful. All right, so I think considering the time constraint,